start the recording. Good morning, everyone. We are very pleased to have Professor Jon Stone, who is a professor of neurology at the University of Edinburgh. Since 1999, Dr. Stone, along with his colleague Alan Carson, has promoted new, transparent, pragmatic, and multidisciplinary approach to FND, which had been a neglected and stigmatized problem. In 2009, he made the first website and now app, the Neurosymptom FND Guide for people with FND at the www.neurosymptoms.org, which we will share, which is now widely used across the world. He has published over 350 articles in the area, including large cohort mechanisms and treatment studies, and led on new international diagnostic criteria for FND. He is currently president-elect of the new International FND Society, which now has about 1,200 members and has received a number of awards, including the President's Medal from the Royal College of Psychiatry and the Ted Burns Humanism and Neurology Award from the American Brain Foundation. Thank you again, Dr. Stone, and we are all listening.
Thank you very much, Emil. It's an honour to be able to speak to you today. And what I've got, I heard it was quite a general audience, so I've got a talk that is looking at, as you see, past, present and future of FND. I think to understand why we're at the position that we're in with this very common condition that we all see in neurology, why we're kind of lagged behind, I think, in our understanding of how to recognise and treat it. But that we're catching up and making progress and where things are going. So there are some practical bits in there as well about diagnosis and how to avoid pitfalls in diagnosis and how to think about communication with patients. So I'm trying to cover a bit of everything today, hoping that that's what people want. And I'll make sure that we leave time for at least 10 minutes for questions at the end. I'm going to put this QR code up at the end as well. If you want some of the material I'm talking about today, particularly there's the handbook of neurology here that I edited with Mark Hallett and Alan Carson a few years ago, and some other review articles, our Lancet review article. There's one focused on management in children as well. And just a slight plug for this. This is out this month's Continuum. We did an article on multidisciplinary treatment for functional movement disorder. As part of that, so it was good to see that in there. There's a podcast as well. We're coming quite close to you next June, Baltimore, we have a meeting every 2 years at the moment. We were in Verona last year. The meeting sold out, so I hope some of you might want to come down to up to Baltimore, I think, isn't it, for that meeting. I'm also separately and slightly by coincidence invited to speak to the National Children's Hospital in Washington, and that's on September the 11th, so just in a couple of weeks, the slightly more pediatric focused talk. So first of all, what are we talking about with FND? There's increasing amount of confusion about this. It's FND sort of been floating about as a term for almost any functional symptom, which it is not. There's a kind of traditional FND symptoms here, the motor and sensory ones, seizures, speech. It probably does include cognitive symptoms and dizziness, which of course are rather different. But that's currently the limit of the expansion. It doesn't mean pain, it doesn't mean fatigue, even though our patients with FND very commonly have those other problems. It doesn't mean, bowel problems, etc. So we'll start with a patient. This is Rachel, university student, came to see me. This was 1 year. She'd seen a neurologist with a right hemiparesis, sudden onset, sort of stroke-like, and been given the right diagnosis, given my website, but that was it, really. So sort of discharged. And this was her a year later.
In an ideal health service, all doctors and professionals would be actually made aware of this. We wouldn't be treated as though, not like we're faking, but almost like as though it's not real. And that doesn't really help us because we're thinking, oh, what's wrong with me?
So you can see in that video the typical clenched fist and inverted ankle appearance of functional dystonia. She had functional limb weakness as well. And it's interesting what she's saying about it's not like we're faking, but it's not real. So patients are often made to feel that they're in that sort of zone of, is this really a thing that that I'm allowed to be here with? And I think many clinicians working in clinical neuroscience actually feel like are not sure about that either, and they're rather ambivalent. So I suppose one of the things I want to do is challenge, think about your own views here. Do you feel a bit ambivalent about this? Do you think this is part of your job to diagnose and manage this problem? I would say it is, but I think you have to make your own mind up about that. So let's just think a bit about the past of FND. It's got a rich and interesting history. This is a film about Sigmund Freud, who was a neurologist before going into psychiatry, and dramatizing a ward round in 1880, Vienna.
With your permission, I would like to make some tests.
Tests? By all means, let us conduct tests here and now, Herr Freud. Gentlemen, I shall use this occasion to enlighten you as to the true nature of hysteria. Be quiet. This woman claims to be suffering from paralysis of the left leg. In a genuine spastic paralysis, the leg would not be so inflexibly rigid. Gentlemen, our paralytic is putting on an exhibition more suited to the Folks Theatre than to a bed in my ward. Her symptoms have been deliberately assumed with the purpose of attracting attention, gaining pity, and escaping the responsibilities of life. Hysteria is another name for lying. Pity there's no therapy for that. You will see to it personally, Herr Freud. This bed is vacated at once.
So hysteria is another name for lying. Pity there's no therapy for that. And I certainly encountered attitudes like that when I was training. And I think it's one way that neurologists particularly have dealt with an area that they didn't feel particularly competent in. It's just to say, well, this is not a genuine. You heard him use the word genuine. The patient claims to be suffering from a spastic paralysis. So again, we're talking about long-standing ambivalence in the neurological profession towards this problem. But actually, if you go back, you will find many sophisticated views about FND going way back here, nearly 200 years. Quite a cognitive neuropsychological approach, really. It's not the muscles which do not obey the will, it's the will itself which does not enter into the action. So that's Brodie in 1837. You've got Russell Reynolds here, way before Freud, talking about about hysteria, as it was then, being a serious condition of the nervous system, dependent on a morbid condition of emotion, idea and emotion, or idea alone. So bringing this idea that there's a sort of cognitive aspect to this, as well as potentially an emotional component, but which is not always present. And Charcot talked about realizing that you couldn't see hysteria after death, assuming that there was some kind of functional lesion in the brain. And people have revisited that, including Mark Hallett in a very nice article in Neurology. So there's a huge amount of material out there from before 1900. This is all for 1920, I think. We knew a lot about this condition. It was a standard part of the neurological curriculum. If you open up Gower's textbook of neurology, there's a huge section on hysteria telling you how to diagnose it, how to treat it. Pierre Janet came and gave a lecture to Boston, I think to Harvard, 20 lectures on hysteria, which is a brilliant read. If you want my top tip for that period, that's the one I would choose. So something happened though, and it was perhaps particularly after World War I and shell shock. There was a bit of sort of embarrassment from the neurological community, I think, about what happened there, and generally losing interest, particularly, and I think perhaps delighted that psychiatry was willing to take this condition on, with Freud's idea of that it was conversion disorder, that a patient like Rachel, who you've seen, is supposedly converting their psychological distress into a physical symptom. And I would say what went wrong here was that it's not that this idea is without some merit, I think, in some patients, but it's a single hypothesis in a disorder that requires multiple perspectives. And it was a very purely psychological dualistic view, really, a rather overly simplistic hydraulic view that took away from the complexity of the disorder, I would say. And then we see later on in the 20th century, psychiatrists also finding ways to sort of not see patients with FND. I would say this was Elliot Slater in Queen Square, suggesting that actually most of the people diagnosed with hysteria, it was misdiagnosed. So these are people, he was suggesting, that did get MS and epilepsy, and that perhaps hysteria is a delusion. It doesn't really exist at all. This data I've had to sort of battle with for most of my career, but it's finally squashing that down. So there was this idea around that perhaps hysteria, FND, was a thing that was around at the time of Charcot. Perhaps it was sort of fashionable then, and then it's sort of virtually disappeared. This is a book on the history of psychosomatic illness, suggesting FND had disappeared. Well, it's just not true, as all of us know who see patients clinically. It certainly had disappeared from the textbooks. And if you opened up a textbook when I was training in the mid-90s, you would not find a section on FND or how to diagnose it or how to treat it. There'll just be little snippets here and there about what to do. So it had disappeared from the training, but it hadn't disappeared from the population, I don't think. So we've had to turn around a lot of issues in FND over the last 25 years, and we are beginning to do this in various degrees of success, depending where you are in the world, I would say. But these ideas from psychiatry, psychiatry and neurology, that it's probably doesn't exist, or diagnosis is wrong, or maybe the patients are making it up. Conversion disorder was very much a diagnosis of exclusion, very much purely psychiatric. And there was often a sort of feeling around that perhaps you didn't need to treat the patient, they would just get better from their conversion reaction. So all of these things are not correct, in my view. And this is where I would position where we are now, a common disabling condition that we can diagnose as reliably as others. That's not to say we should be complacent, using inclusive typical features. It's a disorder that challenges the division that we have between psychiatry and neurology. And for me, that's one of the things that makes it very interesting. I don't think it's not malingering, and I'll explain why. And treatment certainly can help. So let's look at some of these issues. So how common is it? Oh, I had another more up-to-date paper there, but I haven't put it on. So it's probably about 50 to 100,000 people in the UK. So that would scale up to about 500,000, up to 500,000 people in the US. One of the commonest categories of condition that we see in neurology, if you count it. It's amazing how often it's not counted. What about this psychiatric concern that it's misdiagnosed? Well, the historical literature actually, even in the 70s and 80s, shows that it wasn't being misdiagnosed any more than other conditions. And then some more recent up-to-date studies have shown very low rates of misdiagnosis, certainly locally in our cohorts. And of course, there's a misdiagnosis rate with any neurological condition, particularly epilepsy, people being told they've got epilepsy or MS or even ALS when they don't. But I think we do need, as FND becomes more widely known, we do have to be very careful to understand when you shouldn't diagnose it. So here's a patient that was sent to me with a diagnosis of FND.
Yeah, no. Wait. Yeah, sorry.
I was just trying to get it.
Okay, I'm ready.
So just show me what you can. And she exemplified quite a lot of the problems that I encounter with people jumping to the wrong conclusion and making an FND diagnosis. So she's got an unusual posture there, an unusual stance. She was described as having a bizarre gait. She did have some psychiatric comorbidity. She had seen various pediatric neurologists and had been using that wheelchair for several years. Sort of tiptoes. So I don't know if does anyone on the call want to hazard a diagnosis? I can see the chat. Anyone want to put a diagnosis in the chat? Okay, I'm not seeing one. So
Yeah, no.
this is, so she had dopa-responsive dystonia, and she had the gene for it, and her symptoms virtually completely resolved going on to levodopa. So it was particularly unfortunate diagnosis of omission, because she had a treatable condition that was missed. And these are all the things that go wrong, I think. People see someone that looks strange. If you find yourself using the word bizarre, stop yourself and say, that is not how you diagnose FND. It just means you don't know what it is. That's all that word means. And in fact, if to diagnose FND, it needs to look like FND. So if you're calling it bizarre, that means you shouldn't call it FND. Most things get worse when people are stressed, so don't pay any attention. Don't use that to make a diagnosis. Psychiatric comorbidity is very common across all neurological conditions, so don't use that. And a separate issue that I quite commonly see is that people, as FND becomes better known, they're using the term to describe transient symptoms, or someone who's got chronic pain disorder with a slightly weak leg. It's not sensible to call that FND thing. So just try and use your judgment about when it's appropriate to give someone a disorder label, or it might be more appropriate to just label the particular problem. So they've got functional seizures or a functional movement disorder. Diagnosis of inclusion, even though that was sort of absent for most of the 20th century, again, if you go back here to 1922, Henry Head, who's a neurologist in London, was quite aware that the features of FND or hysteria as was then were very typical, and they only looked, that you would only say that it imitated other conditions if you didn't know what FND looked like. So I think we've been sort of thinking about this slightly the wrong way in terms of, oh, it looks a bit like stroke or it looks a bit like epilepsy. It actually looks like FND. You could say epilepsy looks a bit like FND. Would be just as sensible a statement, I would say. And there are lots of these typical clinical features. This is from an infographic I did for BMJ article, just doing some of them, and hopefully many of you in the audience are already familiar with these types of features, and I'm going to run through a few of them, but there's so many, I haven't got time to show all of them to you. I would argue FND is a kind of subspecialty of neurology, if you want to learn all of the disorders and clinical features that we have. These have remained remarkably consistent over time. Here's a video from over 100 years ago of a soldier with functional leg weakness, he'd had shell shock, if you like, had an injury to his leg, which is quite typical to get functional limb weakness, and he's dragging his leg with the forefoot in contact with the ground. That's the key feature. He had some treatment from Arthur Hurst, a neurologist, and here he is a lot better. So I've personally learned a lot about treating FND from reading this sort of material. What did they do with people with shell shock? And it was a very multidisciplinary approach, in which the diagnosing physician took part in that process, and it wasn't left to someone else just to do all of the treatment. You can see very similar gaits here, often with the hip externally or internally rotated. Here's another typical clinical feature. Lucy, who was a successful businesswoman who presented with a stroke-like episode, and I'm just asking her to show me her teeth, and it triggers this functional facial spasm that's very typical. Show me your teeth. And just try and keep your mouth in that position and then relax. And that does seem to have made it a little bit worse. Can you have a look? Can you feel the contraction?
Yeah.
Just show me where you feel it contracting.
I feel it here.
Yeah.
And then it starts to come down here.
Yeah. So you're looking for this very characteristic platysmal contraction, which causes the mouth to go down. And it's often interpreted as facial weakness, but it's not. It's muscle overactivity. And sometimes you get scrunching up of the eye on the same side. So sometimes the corner of the mouth goes up. I'm not aware of any other condition in which that occurs. So it's a good example of a typical clinical feature. Show me your teeth. Here's a man having a functional seizure. And I guess the point I'd make here is that even before I'm pressing play, you can see many you can see some things that help him with the diagnosis. His eyes are tightly closed. His hands are in fists and flexed. Then when I press play, you're going to see a tremor-like movement this is not clonic. Of course, it will be described as tonic-clonic by people because that health professionals feel they need to use the right words. And of course, they'd be better off not using those words because they often don't know what they mean. This is a tremor, which is asymmetrical. It's waxing and waning. There's some side-to-side head movements. The event's going on for a long time. There's some hyperventilation. Numerous features of a functional seizure, which we can see just within a few seconds. So, of course, lots of evidence now that smartphone videos are really helpful for diagnosis. Not 100%, of course, but I think in our practice locally, we're doing a lot less video telemetry than we used to because most of the time, now that we're more familiar with all of these typical features, we can be much more confident about what we're looking at. Of course, that person may have epilepsy as well. 20%, up to 20% of people do. And I haven't got time to go through all of these other FND features, but they're all available in the various articles I'm going to link to. So definitely a diagnosis of inclusion. What about Freud's this conversion psychiatric model? Well, it's psychological and neurological. When people use the word, another word that I'm going to try and discourage you from using today, which is perhaps more controversial, is the word organic. So we often use that, don't we, as a sort of catch-all for things that are not functional. But I think probably the phrase we should be using is non-functional, because this was an article we wrote for Practical Neurology about that word. And you can see I'm slightly tongue-in-cheek here. Picture of 2 organic turnips, because a picture of a non-organic turnip is philosophically impossible. Just as a non-organic human being is impossible. So how can a human being that's 100% organic have a non-organic condition? Would be the question I would ask. I don't think it can. So I think we should get away from this term organic. And these are getting at the heart of what do we think's going on in this disorder. People got very excited when they first saw that there might be correlates of FND symptoms in the brain. And it is exciting, and we're learning a lot more about that. But I would also say, well, where else did you expect it to be? Which other organ was going to be affected? So we sometimes have this problem, FNDs have this problem that it's somehow not, non-organic, not in the brain. Of course, it's in the brain. And this is a nice study from Mark Hallett, Valerie Voon, just down the road from you, looking at patients with functional tremor compared to the same patients making a voluntary tremor. So what's the difference between the voluntary movement that they know that they're doing and the involuntary functional tremor that feels like they're not doing it? Well, it's an area in the brain, temporoparietal junction, which is a really important node in that sense of agency, parts of the brain that tell you that it's you doing it. So that was a nice result. And that area and the networks around it have come up over and over in functional imaging studies. So a kind of disorder of brain agency of movement, kind of what the patients are saying. And of course, it's not just that, various other networks related to emotion regulation, particularly networks related to threat or shutting down the brain, attentional networks, etc. So a work in progress, but we're making progress. Another way of looking at FND pathophysiology is to think of it as a disorder of brain prediction, and to appreciate that actually prediction is actually how probably our brains are working most of the time. That when I do things like pick up this cup, which I'm going to do because I want to have a drink, I have some idea of how heavy that cup is, so that when I go to pick it up, I grab it in just the right amount. I don't throw it over my shoulder. So I'm predicting things constantly, including what I'm looking at even, and sensing. And there's a whole ream of evidence to support that this is perhaps how the brain works, and this is an example of it here. So you will only hear the word that you're reading. You can hear that okay? So just try reading the other one if you haven't done already. And it's pretty dramatic. When you read the other letter, you get a completely different perception. And if I was to get you to close your eyes, maybe those of you on the call could just close your eyes, and I want you to predict now whether you're going to hear the words green needle or the word brainstorm. Just close your eyes. And generally speaking, you experience the words that your brain is predicting more than so your top-down expectation of what percept you're going to have matters is weighted more than the sensory input coming the other way. So there's a book by Andy Clark about this phenomenon, which has a section on FND, which I was involved with. And people who are interested in predictive processing become interested in FND as a sort of disorder that really speaks to that issue. And rather than a condition that breaks the rules of anatomy and physiology, a disorder that you would expect to occur based on our new understanding of brain pathophysiology or physiology. So it explains other things as well that perhaps you wouldn't call a functional disorder, like phantom limb. There's a brain that's strongly predicting that a leg is there, and it's ignoring sensory input, telling it that the brain isn't there because the prediction's so strong. So it's about updating, so predictions not being properly updated by sensory input. And here we've got a patient with functional paralysis, and here the prediction is of a leg not being there or a leg that is not working. And again, the same problem. The brain, that very strong prediction is not updated by the sensory input telling the brain otherwise. You can see this clinically if you speak to, you get little glimpses of this phenomenon, I think, when you talk to some patients. So here's someone with functional dystonia like Rachel. I'm asking her to close her eyes and tell me what the foot feels like. When you look at the foot, you can see that it's bent, obviously.
Yes.
Yeah. Can you just close your eyes for me now? And just tell me what that left foot feels like with your eyes shut.
It feels like it's straight.
Okay, it feels completely straight.
Yeah.
Okay, and then when you open your eyes and you look at it again.
And then I can see it's bent.
Yeah.
Although.
So is that what is that? Is that a strange feeling? That difference between?
It feels strange because although the foot's bent and I know it's bent, when my eyes are shut, it's straight.
So, and you can use that actually, I'll come on to this later, but in terms of explaining to patients what's going wrong, these sort of, if you have a foot that looks like this lady's foot, it would be fairly reasonable for you to think there's something wrong with your foot. So what our job is, of course, to try and explain to people, no, there's something wrong with your brain. And doing simple things like this it can be quite effective ways of pointing out that the brain has gone wrong. You know, your brain thinks your foot is straight. This is your brain's new normal. So when we try and straighten your foot, that's why it's really difficult for you. It's like me trying to bend my own ankle outwards. It wouldn't feel like a normal thing to do. So you can get pretty excited about predictive processing and brain networks and agency, but what about all the stuff Freud was talking about and stress and conversion? Is that of any relevance? And the answer is yes, it is, because particularly traumatic experiences are very common in people with FND. They're not just psychologically traumatic, like neglect, for example, which came up quite highly here, but also particularly physical experiences, being physically threatened, or if you've been repeatedly threatened or abused when you were young, then you develop a strong sort of, perhaps an amplified threat response. And threat responses involve disconnection and dissociation. That people's brains learn to do that in response to threat. And that threat later on in life might be an injury or pain. It doesn't have to be a stressful event. And there are definitely people out there, lots of people who've not got a stressor that is necessarily relevant. I mean, and the other problem, of course, is we're all stressed to some extent. So how do you decide whether a stressor is relevant? So stress is relevant, but it's a risk factor, not the cause. having another neurological condition is probably as strong a risk factor for FND as abuse trauma history. So having a bit of MS, having had an epileptic seizure or a faint, or being in the prodrome of Parkinson's disease. And I think it's really, for those of us who work a lot in this area, that's really comes home to you just how common this is, and why the first thing you should do when you diagnose FND is think, well, what else has this person got that I'm missing? Neurological disorder comorbidity, very common. We're also appreciating developmental issues or personality differences, particularly ASD and ADHD, probably more highly represented. And there are good reasons why people with ASD are perhaps more likely to get FND. And if you talk to people who've developing a functional movement disorder, for example, here, you will find, if you ask carefully, you will find, particularly those with a stroke-like onset, that there's often been a bit of a panic attack at the onset, or an injury, or an infection, or drug side effect, migraine with aura. I've just written a paper about that, the brain communications. So instead of just this very hydraulic, rather simplistic conversion model of Freud, which we don't need to dispose of, but we need to integrate that with all of these other things, we end up with this sort of model predisposing, precipitating and perpetuating. So you've got someone who's, for various reasons, has a brain that's a bit vulnerable to this, a sense of agency, its ability to disconnect, its connections to emotional systems are a bit, make some people more vulnerable than others. And then there's often a triggering event which is more identifiable, and it varies depending on the symptom, an injury, a faint, for example, panic attack. And the brain gets stuck. So the brain gets stuck as if the injury or that inciting event has just happened. So as if the leg is still painful 3 years later, even though the injury is long gone. And the brain's still in protective mode or shutdown mode. And the experience of the symptom itself is stressful. And it gets mixed up with lots of other pre-existent or subsequently developing comorbidities. It gets mixed up with all of the difficulties these patients have navigating our healthcare system, often with people who don't really understand their condition or know how to recognize it or treat it. So here's a more complicated etiological model to work with. And this is, I think, to need to treat someone, it does help sort of think about all the different aspects, and everyone's a little different. Everyone needs a slightly different formulation of their problems. What about malingering? Going back to the Freud video I showed you. Well, there's no definite way of showing why an individual patient is not malingering. But we wrote this article, I wrote Mark Edwards, Mahinda Yogarajah, laying out all the evidence for why feigning malingering just doesn't offer a particularly persuasive explanation for what's going on here. For those of you that are feeling a bit ambivalent about whether this is something that you're supposed to be, is part of your job, or that you should be interested in. And there's a variety of evidence, such as the consistency of these physical signs over time, and across the world they're very similar as well in all cultures, economic groups. But particularly the imaging evidence from neuroimaging and neurophysiology, we're seeing things happening in FND that would be virtually impossible to feign, like this study of Mark Edwards on sensory attenuation, which is hard. I haven't got time to explain it all to you, but basically I wouldn't know how to feign this dose response curve that he got in FND, showing actually improved accuracy at some tasks. So I think there's a variety of evidence why it doesn't make, responding to therapy, for example, in an RCT, that doesn't really make sense if someone had a malingered feign deficit. So it does exist. There are people out there feigning and malingering, particularly in medical legal scenarios, but it's not a major issue day to day in FND. And we go back 150 years to James Paget, of Paget's disease, who said about functional paralysis, the patient says I cannot, it looks like I will not, but it is I cannot will. And then what about treatment finally? So this was quite a long time ago now, we proposed this very basic sort of stepped care model But one of the key things about this that we were trying to get across then was that the neurologist or the person making the diagnosis is a key part of treatment. They're not just, it's diagnosis and initial management, not just here's a diagnosis, off you go. It makes a huge difference if that person stays involved with the patient. And when we think about communication, I know a lot of people struggle with this with FND, and my observation over many years now, thinking about this and teaching it, is that actually the answer to this is very straightforward. What nearly always goes wrong in FND is that people don't do what they normally do, but they do something weird. And so the answer is stop, but don't be weird. Stop being weird. Do what you normally do. How do you communicate with someone who's you're telling has got migraine or Parkinson's disease or epilepsy? Do that. So this would be an example of very direct and straightforward communication about what's wrong. Explained, when you're telling people what's wrong with them and saying, I know what's wrong with you, look, here's the evidence, here's the scan, here's the blood test. In FND, you can't do that. So you have to show them the evidence clinically. And this was an article we wrote for Neurology about turning these diagnostic tricks that we have into treats for the patient. So here's me doing this with Rachel, hip abductor sign. You'll see.
Can I just get you to push against my hand here? We can see when we do that, you're stronger than I am, and I can't push that knee in. And then let's try and do the same thing with this knee. So stop me from pushing in, push out as strong as you can. But I'm winning there, pushing your knee in. Let's go back to this side. I want you to push out again as hard as you can. Really stop me, push, 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 push. Now when we do that, we can see that actually what's happening over on the right side is that it's become much stronger and I can't push the knee in now. So it's brought out the automatic movement.
So I don't know how many of you would show your patient the Hoover sign or the tremor entrainment test or hip abductor sign, or here's a picture of someone else. But for me, these are the things that I do that I get the most value from, or the patients tell me afterwards. If I say to them, how was I able to get you confident about this diagnosis when that last person couldn't? And they said, it's because you spent some time showing me these signs. So I would really encourage you to do that if you don't. It's a great relief often to patients to say, look, you've got typical features of this condition. That's why I'm diagnosing it. If you think about those patients who do have FND and Parkinson's or FND and MS, it becomes increasingly important to explain to them why you're making this diagnosis. So, and you're showing here the difference between the voluntary movement, which is impaired, the more Rachel tries, the worse it is, and the automatic movements when she's distracted, when it's better. And then you start to see how that will feed into therapy. So in physio, we want a physiotherapy treatment to promote those automatic movements and to squash down those abnormal voluntary movements that are impairing movement. So it's actually getting rid of the top-down predictions, if you like. Information matters, and so I made this website, over 15 years ago now. It's sorry, this is a German version for some reason here, but it's in a few different languages. There's an app, and there's a way of, if you click on this little bookmark here, you can recommend certain pages to patients. It's a bit overwhelming, this, so I'll be careful just saying look on the website, because they may not find what it is you want them to look at. So recommending pages helps to tailor their information a bit. We now have quite a lot of information about the treatment of FND. In fact, we're about to have an American Academy of Neurology guideline for treatment of functional seizures with psychological therapy. It's coming out in the next month or two, I believe. And we wrote these ones on speech and language therapy, OT and physio, to try and help the general therapist, particularly those working neuro scenarios, to know what are the similarities, but also importantly, what are the differences? And there are important differences we think, in the therapy of FND, based on some of the things I've already been talking about, that symptoms are worse when people are trying, they're better when they're distracted. What's the evidence for all these treatments? Well, it's growing, I would say. We still need better evidence, mostly small studies. For psychological therapy, we have this quite large study in 400 patients with functional seizures. The primary outcome was the frequency of seizures, and that improved in both groups. There was a group with having additional cognitive behavioral therapy. Personally, I think seizure frequency is not a great outcome for functional seizures. I think what matters more is whether seizures interfere with day-to-day functioning or not. So if someone's at work, they can go in a cupboard, have a seizure, come out again, carry on their job. That's a completely different scenario to where an ambulance is called, for example. So it was positive, I think, for most of the secondary outcomes, and particularly the ones that mattered. So I think we do have some evidence. It's helpful. Here's the Physio 4FMD trial. It's the largest trial of physio, and I'm partly showing this just to say that these manuals are now freely available. So if you have colleagues in physiotherapy who want to use the manual, there's a patient workbook that the patients really enjoyed using, and then there's a manual for the physios as well. And it's Glenn Nielsen, a physio in London, that really led on this. But pointing out some of the many things that are just a bit different for when you're doing FND. You don't want to make the patient think really hard about their leg. You might want to get them to do rather unusual things. As this video shows here of Miranda, who's a primary school teacher in Australia, got a functional gait disorder, and she sent me this video after she got better and said, which I was then able to post, and she'd sort of making up, she went along with her physio, but she discovered that she could run but not walk.
In some regards as well, because I'd tried to have a positive attitude for a lot of it, but when you just don't seem to be making any progress, and I didn't feel free. I felt very, very trapped in hospital. It was really amazing when I could run again.
I have never seen someone like Miranda before. And even though she could not walk, or she could not even stand by herself, I took up the challenge to put her on the treadmill.
My mum was there filming at the time, and she thought that it was crazy. And then he just made it faster and faster, and that's when we discovered that I could run. I could go quickly, but not slowly.
And in fact, that's one of the diagnostic tests that you might do for someone with a functional gait disorder, get them to walk backwards, get them to jog on the spot. Got to be careful. There are other conditions that might be a bit better running, like vestibular disorders as well. But here, an example of how a diagnostic test then becomes part of the treatment for this patient.
And
here she is just talking about her recovery.
That was no idea how Sam and I, we were in-depth conversation, and then it wasn't until we were halfway down the street that we both realised that I was walking like normally.
That is a miracle.
And my biggest fear then was to stop walking. I just kept walking because I was like, if I sit down and stop, what if I can't walk again?
So obviously, it doesn't always work like that. Many of these patients are very complex and difficult to help, but there is definitely a group, quite a large group, where you can make a difference to varying degrees, I would say. And in that trial, again, the primary outcome, both groups improved. It's the difficulty of doing trials in FND for a group that often haven't had intervention, but the self-rated improvement was higher in the FND physio group. So this was me trying to persuade you of these 6 things that I think are different to where they were when I was training. Briefly, what about the future? Well, we've got an FND society now. I mean, this is our meeting last year in Verona. I'm very excited by how large that society's become. We've got about 1,200 members now, and it's a multidisciplinary society. If you have people who want some sort of basic training on FND, we've got 3 sort of courses now. So and trainees can join for $50. These are 15 hours of lectures and about diagnosing and treating FND. There's another one for psychological therapy, and there's another one for rehab as well. We've got others coming. The other thing that I think is really positive and exciting is that we have patient-led organisations for FND, which I think a lot of people were a bit sceptical about. I've personally found them really helpful. I think it shows that we can work with a disorder that has been incredibly stigmatised and come out with sensible patient-led and health professional interactions, whereas in other functional disorders that hasn't always happened, or it's become very polarised and political. This is a patient giving a lecture at our Boston meeting, getting a standing ovation because it was such a good lecture. Where will we be in 10, 20 years with FND? Well, brain imaging is improving all the time. This is it's an interesting study saying, can you just look at someone's brain resting state fMRI and decide if they've got FND? Well, obviously not yet, but 72% accuracy compared to healthy controls is an interesting start. And people are interested in actually what, if you have FND for a while, does that change the structure of your brain? Almost certainly does. Genes will definitely be relevant, I think. People are interested in the rest of the body, so it's not just about the head as the autonomic nervous system. And these patients very often do have, of course, other functional disorders, irritable bowel, chronic pain, breathing pattern disorder, etc. People are interested in novel treatments. So can we use things like virtual reality, psilocybin, neurostimulation, or digital therapy AI to help? I think we probably can. Just be careful how we do it. In the UK, at least, things have really changed. FND and neuropsychiatry is one of our 8 core topics in the curriculum. It used to be very much a tiny sort of outlier, so I'm pleased to see it sort of taking centre stage. I think that's different in other places. I don't know how things are going in the American neurology curriculum. But in reality, many patients day to day still struggle a lot to access anyone that's interested in their problem. Or there's quite a lot of misinformation out there as well. So here's someone saying, if someone tries to diagnose you with FND, fire them immediately. My own doctor told me this. So there's your CME credit code that I've been asked to give you. I'll leave that up for a second. Hopefully you have another way of getting that. But then I'd just like to thank you for listening, and hopefully we've got some time for questions. That's the QR code for the FND material. Thank you.
Thank you, Dr. Stone. It was an outstanding talk. And I do have actually some questions, if you don't mind, and we do have some questions in the chat box. So the first question is, what are your thoughts about, or like possibly hypotheses about the latency period between, for example, patients who have a traumatic experience and then years later they might develop the symptoms, the functional neurological symptoms. So what are your thoughts about this latency period? Why some patients would have years of latency periods, other months, and what's your thoughts about it?
I suppose the way I think about that is, as I was mentioning before, if you've been, sexually abused by your uncle for several years when you were growing up, then you can sort of see how repeated threat to bodily integrity. I think when you talk to people who've been in traumatic situations, they often learn to dissociate as a response to threat and injury and pain. And so I think people just grow up with a brain that does that much more easily than average. So when they're later on presented with an injury, pain, or a surprising event that threatens their integrity somehow, I think that's how often you can draw those things together. I think you've got to be very careful if you're meeting someone for the first time to jump to that. And there's a tendency for neurologists to want to solve patients like a puzzle. So I know why you've got this. So I would really, as a clinical tip, I'd really suggest you can make a mental note of it, but pull back a bit unless the patient really wants you to. That's often making those links, working out why there was such a latency is a goal of treatment rather than something to sort of solve for the patient straight up. You can actually cause harm doing that, I think.
Thank you. And my other question is why you mentioned one of your slides that, for example, triggering factor for functional seizures, for example, could be history of epilepsy or syncope. But sometimes we patients would present without any of these, like they will not have history of epilepsy or syncopal events, and they can develop functional neurological disorder. Seizures. Others would develop a functional movement disorder. Why some patients develop a specific type of a functional neurological symptoms and others have other types?
I mean, I don't think it's always clear, but I think very often my own research and that of others in seizures is that the first event, the first event may be something different, like a faint, but often the first event is a functional seizure, or quite commonly it's a panic attack. And if you think about panic, one of the 12, 15 symptoms in a DSM-5 panic attack is dissociation. It's a feeling that the person's spaced out, not there, not in the room. So dissociation is a core feature of panic, and that in panic, the experience of dissociation is itself terrifying, and that's why things escalate. So I think I think panic lies behind many of those situations. You can also make the argument that dissociation, falling down to the ground, lying still, falling down to the ground, shaking, has almost certainly a sort of very strong evolutionary origin. So these are they have a lot in common with freeze responses that you see in animals who are threatened, or a mixture very probably of freeze response with a fight or flight response all happening together. So sympathetic and parasympathetic activation occurring at the same time. Why do people get other symptoms? It's because functional movement disorder, that surprising and novel stimulus has come to that particular body part. So they've been injured. Sorry, my cat is meow. You can probably hear. But it's been injured in a certain limb, and then that's the limb that feels threatened, and then your brain dissociates that limb. So I'm just going to chuck my cat out of the room, but do keep speaking.
We have a few questions in the chat box. So I'm going to move to the chat box questions because I do have one more, but let's give room for everyone. So we have a question. What is the prevalence of FND in children?
Yeah, so I think where we're coming to with the epidemiology, it looks as if, it's very rare under the age of 10. So there's something about, it does happen, but it's pretty rare. So it becomes much more common as you go through the teenage years. It gets more and more common. The peak, the actual modal onset, for example, of functional seizures is actually 19 years old. So almost it's in the teenage years is the most common. So I think it's a disorder that is the same disorder in children, probably with slightly different risk factors, less of the abusive stuff, more kind of peer pressure, school problems, perfectionisms, a lot of high achieving athletes who are not used to being ill, etc. But I think the fundamental disorders very similar. There's an interesting, slightly less in the way of gender bias. So in adults, you see 3-to-1 female to male, whereas in younger children, older adults, it starts to head more closely to 1-to-1.
We have a question by Dr. Casavetes. What is the optimal duration and intensity of physical therapy, and how often do you see patients achieve remission or sustained improvements with also long-term follow-ups?
I don't think we know Panagiotis, but I think that's partly what the Physio for FMD trial was about, because the idea was, we think that essentially, if you think of FMD, functional movement disorder, as a bad habit the brain's got into, and that the brain thinks is normal, you're trying to sort of retrain a bad habit. It makes sense that it's perhaps better to try and do that in a more intensive fashion if the patient can handle it. Not all patients can. My experience is that, having that more intensive therapy with the right patient at the right time is better than, for example, them being seen once a week, where perhaps they haven't made those gains. I think you definitely need to think of FND as a relapsing condition. If someone comes back to me in clinic feeling a lot better, and that does happen quite a lot, or they're moving better, I would say, well, how are you going to manage when you wake up on a Tuesday morning and your legs don't work again? So part of the workbook for this was to sort of think about managing relapses, how to do that on your own, perhaps having a series of relapses that are not as bad as the initial event. Long-term outcomes are very variable. It's sort of rule of thirds, improved, a bit better, same or worse.
Another question is, how do you approach the discussion of driving with patients with functional seizures?
So in the UK, it's relatively straightforward because quite a long time ago, maybe over 10 years ago, our driving license authority decided that you could not drive for 3 months if you had a functional seizure. So they developed a specific rule for it, and so we just have to communicate that. I know in other parts of the world, the US, there's a paper coming out on this soon as well. There isn't such strict guidance. I personally think the risks involved in driving are minimal. I think when people are focused and distracted, they're not likely to have a seizure. I think it's the same reason you don't see life-threatening injuries with functional seizures. That's not to say it's not possible. It is possible, and some work from Australia has documented some patients with functional seizures having dangerous experiences driving. But I've only ever met one patient who had a dangerous experience driving. I've only ever met one mother who caused a minor injury to her baby from a functional seizure versus 25 years of not ever hearing that. So
we have a question about autism and the link between autism and FND. And the question is, if I understand well, could FND is a spectrum of disorder of schizophrenia? And what's the response to antidopamine drugs?
Yeah.
And the comorbidities of psychotic disorders with FND.
So it's a question about comorbidity of psychosis and autism. I think they're different things really. So the autism spectrum, of course, the goalposts have moved a lot with that in recent years. So we're seeing a lot of people with mild autistic spectrum, and there are good reasons why that is a bit more common in FND, to do with things like being able to label bodily states, particularly emotions, but also other ones, just labeling pain and things as well. Interesting. I think the comorbidity with psychosis is actually lower than you'd expect from the population. So good going. If I see someone with FND who's got a diagnosis of schizophrenia or schizoaffective disorder or bipolar, I find that psychosis diagnosis is often wrong. It's often someone with, for example, with bipolar, it's often someone with emotionally unstable personality, or the schizophrenia is more like a sort of borderline personality disorder type of, the patient had quite vivid hallucinations, but they are based on trauma. So it's a complex PTSD. So I do wonder, actually, good going schizophrenia, I sort of think of as a horrible degenerative brain disease, which I think actually destroys parts of your brain that you need to have FND, those very sort of self-referential, introspective parts of, sort of networks in the brain. But that's just a thought. There are similarities in terms of predictive processing, but I think there are different conditions, really, not on the spectrum.
We have a few more questions if you have time.
Yeah.
So is it useful to think of FND as a disorder characterized by misperception of control? That's a question also from the chat.
Yeah, I guess so. It's definitely it is a misperception, but it's not always perception, is it? Sometimes it's action. So and misperception is a bit of a problem because the patient perceives that they are weak, and they are correct that they are weak. So yeah, I'm not sure I would, but it does. It's close to what I was saying about Paget saying it looks like, it looks like I will not, but it is I cannot will. Yeah, it's close to that, what you've just said.
Another question is, what's the rationale of calling functional seizures by that term rather than calling them functional episodes?
Yeah, well, this one will run and run. So we've been, I think I would say FND itself is not, I don't necessarily like that but I think it's the least worst term that we've got. It's an attempt to be something that is not jumping to conclusions about why the person has it. There are lots of arguments to and fro about why, I appreciate that seizures can be unhelpful because it suggests to people they might have epilepsy. If you say to people episodes, they'll say, well, everyone else says they look like seizures. So I think you have to use terms that you're comfortable with. At the moment, the research community and the patient-led community prefer functional seizures, and I'm okay with that too. So but it's the least worst term. Dissociative seizures is another one. The ILAE have just produced a document saying that they think functional or dissociative seizures are the current most preferable term.
Little bit of another question actually is autism disorder in young tend to be schizophrenic disorder?
Well, I'm not sure that's true really, but yeah, I think there is an overlap between. That's a separate topic, so I would maybe the person could email me, and I'm happy to discuss that, but I don't think that's true.
So we have two more questions. So basically, what is your experience with psilocybin therapy for FND, and is it used to create a dissociative state in order to reorganize the neural network more readily? And otherwise, what are the theories about psychedelic therapy?
So people are starting to, obviously it's sort of fashionable treatment, isn't it? But Matt Butler in London is looking at this very carefully, and Maudsley with functional imaging as well. I think there's so much of, if you know about what happens with psilocybin therapies, there's so much placebo involved, so much things that are nothing to do with the mushrooms, basically. Getting someone in a very comfortable environment, spending many hours with them, talking to them and taking them seriously. These are the problems we have with doing clinical trials. If you do these things to people with FND, it helps them. Simple, basic things like that. And I think there are risks as well of getting people who already have a tendency to dissociate into more of a dissociative state. That's probably the reason that diazepam is a bad idea for most people with functional seizures. Not all of them, but a lot of them, it makes them more dissociated and more out of control. So we have to approach these things very carefully. But there may be, particularly for people with traumatic experiences, perhaps it can help shake people out of this sort of stuck brain state that we were talking about with FND. So that's the rationale for using it.
And the last question is, can you comment on FND and long COVID?
Okay, controversial question. People have often talked about that. In fact, of course, most people with long COVID don't have paralysis and tremor and seizures. But we did see a big explosion of videos on social media of people who clearly had FND symptoms after a vaccine, and that was being used by the anti-vaccine community. There are quite a lot of, as there is some evidence of FND symptoms being present in long COVID, but this is where it becomes interesting to think, can we use these same principles to diagnose cognitive symptoms and dizziness, which are core symptoms of long COVID? Can we find the Hoover sign of a functional cognitive disorder? And I think we probably can, but that research is ongoing. So it would take another half an hour to go through all of those, go through the whole of long COVID. But I think you've got another disorder there triggered by a physical experience of an illness, which is happening. But then is it the same condition 3 months later would be my question. I don't think it probably isn't.
Maybe we can have this as another Grand Round topic.
No.
Well, thank you so much, Dr. Stone. That was outstanding. And the CME is again in the chat box, and we will have this recording on our website soon.
Great. Okay. Well, hopefully, available to the people of George Washington University mainly. I would hope, yes, rather than YouTube. But yeah.
Will this? I will reach out to you.
Yeah. Okay. Thank you.
This regard, yes, absolutely.
Yeah.
Okay.
Great. Well, thanks very much, everybody. Thank you.
Thank you. Bye.
Bye.